In this video, we'll discuss about the HRCT patterns of lung diseases, especially in the interstitial lung diseases. So what is HRCT in first place? HRCT is high resolution computed tomography in which sections are of 1 millimeter thick or less than 1 millimeter thick. This is nothing but the normal contrast CT which is reformatted after acquiring into thin slices. Since the advent of a spiral CT, HRCT is not a different protocol. It's just reformatted images from non-contrast CT. What are the indications for HRCT? Suspected cases of interstitial lung diseases. In cases of cystic lung diseases. Small airway diseases which show mosaic pattern. And if micronodules are present, etc. These are the indications for HRCT. They present as different pattern of opacities which we will discuss in detail in this video. So here we can see the periphery of a lung. The smallest unit of a lung visible on HRCT is the secondary pulmonary lobule. So we all know that alveoli is visible on the histopathology, not visible on CT, but the smallest unit visible on CT will be secondary pulmonary lobule. We'll discuss what are the structures within the secondary pulmonary lobule and its anatomy in detail. Now the secondary pulmonary lobule is the smallest functional unit of lung which is visible on HRCT. Each lobule is of size 1 to 2.5 centimeters, separated by interlobular septa. Each lobule contains 12 or fewer acini within it, and it's centrally supplied by centrilobar bronchiole and centrilobular arteriole. This is the pulmonary arteriole. Within the interstitium or the pulmonary septa, there is pulmonary vein and lymphatics running through the septa in between pulmonary lobule. Centrilobular bronchiole divides into terminal bronchiole, which then divides into respiratory bronchiole. That will go on further to divide into multiple smaller branches which supply the acini. These are the acinar bronchus or acinar bronchioles. The last or the functional unit of the lung is acinus or the acini. Along with the bronchiole, we can see lobular arteriolar branches also will supply up to the acini. Remember this image or these structures very well, because next when we are discussing about the opacities, all these will come up, and these are the responsible for different types of opacities. So we can see interlobular septa here, along which pulmonary vein and lymphatics is running. So this is the interstitium. So whatever we call interstitial lung disease are the diseases of this interstitium containing pulmonary vein and lymphatics. So along the pleura also we have this interstitium running, not only in between the secondary pulmonary lobule. Along the central lobular bronchiole and lobular artery also lymphatics run. This is nothing but peribronchiolar interstitium. So this is also part of the interstitium. So interstitial lung disease can affect any of these structures. We'll see some nomenclature related to secondary pulmonary lobule. So this area around the centrilobular bronchiole and arteriole is centrilobular area. Just around that bronchus and arteriole is centrilobular area. Diseases affecting this centrilobular area are through airway spread or the vascular spread. It is well understood because they are around the airway and the vascular structures. So this area in yellow, whatever I am marking, is the interstitium. We learnt it. So this area is also called as perilymphatic area. That's because lymphatics run through this interstitium or interlobular septa, and whatever diseases affect the interstitium is because of the lymphatic spread, because lymphatics run through it. Simple to understand. Next we have one secondary pulmonary lobule here, one more lobule here. In between the lobule we know that it is interlobular septa constituting the interstitium. Coming to the main part of the talk, that is HRCT findings in lung disease. So now we saw the secondary pulmonary lobule and its structures. So multiple diseases affecting these structures produce multiple opacities. There can be increased lung opacity as such nodules, linear abnormalities, ground glass opacities, and consolidation. In nodules there are three types, that is centrilobular nodules, perilymphatic nodules, we all saw these areas, and random distribution of nodules. In linear abnormalities we have interlobular septal thickening, we have subpleural bands, there are parenchymal bands, and diseases producing decreased lung attenuation are as follows. There can be emphysema, lung cysts or cystic diseases of lung, bronchiectasis, and honeycombing changes. So these are the opacities which we will be discussing in very much detail from now. First and foremost we have the nodular pattern of spread. So there are three types of distribution in nodular pattern: centrilobular distribution, perilymphatic distribution of nodules, and the third one is random distribution of nodules. We'll discuss each in detail. So here I am drawing secondary pulmonary lobules. Now I am putting some dots which are centrilobular in distribution. They are centrilobular nodules. And here what we can see along the interlobular septa, along the fissures, all these are, and along the peribronchiolar areas, all these are the perilymphatic distribution of nodules. And some things which are randomly distributed which do not fit into the above two are the random distribution of nodules. Centrilobular distribution is when nodules are present along the centrilobular bronchiolar arteriole. So since they are spaced so far from each other, they are equally spaced nodules. They spare the pleural surfaces since they are present in the center of the nodules. They spare the fissures. They are usually 5 to 10 millimeter away from the pleura. Here we see that this is the centrilobular area where the nodule will occur. It's because of diseases having airway spread or the vascular spread. Yes. Next we see conditions presenting as centrilobular nodular distribution. Hypersensitivity pneumonitis, especially early stages or acute stages. Respiratory bronchiolitis, since it spreads through bronchioles, it's centrilobular. Infections like endobronchial spread, which showed by TB, bronchopneumonia. Next, bronchoalveolar carcinoma, as the name suggests, spreads through bronchioles. So now I'll show you a case of centrilobular distribution of nodules. Here we can see some ground glass attenuation nodules which are equally spaced from each other. These are ground glass attenuation centrilobular nodules which are showing sparing of subpleural surfaces. They 5 to 10 millimeter away from pleura. Also there is peribronchovascular area sparing. So there is a variant of centrilobular distribution, that is tree in bud appearance. Here we have centrilobular bronchus and centrilobular nodule, which is solid attenuation nodule. This can also be a ground glass attenuation centrilobular nodule. We should keep that also in mind. If there is endobronchial spread of infection, the nodules will look something like this. they'll be along the bronchioles. So whichever disease shows endobronchial spread of disease will show this branching pattern of nodules. This is along the centrilobular bronchioles. These are impacted bronchioles which appears like tree in bud. Condition showing this is infections like tuberculosis, Mycobacterium avium complex, and fungal diseases. Pyogenic may also show, and some airway diseases like cystic fibrosis, where mucus plugging can happen, and in case of aspiration, pneumonia. We'll see these are the tree in bud opacities. In our case here we can see beautiful branching pattern of nodular distribution. This was a case of tuberculosis proven. This is the tree in bud opacities which we talk about. In close up here we can see that very well. Coming to next pattern, that is perilymphatic distribution of nodules. This is the perilymphatic area, wherever the lymphatic runs, that is in interlobular septa, along the pleura, along the fissures, along the peribronchovascular area. So diseases spreading through lymphatics will show nodules in these areas. So these nodules are seen in relation to the pleural surfaces, the interlobular septal surfaces, and in peribronchovascular lymphatics. Also, they are along the fissures. So conditions showing the perilymphatic distribution of nodules. First and foremost, main disease is the sarcoidosis, which is granulomatous disease. Next is lymphangitis carcinomatosa. Whatever has lymphangioma, lymph name within it, has perilymphatic distribution. So silicosis, coal workers pneumoconiosis, since these are cleared by the lymphatics, the particles are cleared by lymphatics, they are spread also along the lymphatic distribution. And asbestosis. Sarcoidosis is the most important one you have to remember. So here we can see perilymphatic distribution of nodules along the peribronchovascular interstitium. The bronchovascular structures are studded with nodules. This is a case of sarcoidosis. Also pleural surfaces are studded with nodules in focal areas. This is a case of sarcoidosis with perihilar and upper lobe predominance. Look for hilar nodes. Coming to last nodular distribution, that is random distribution of nodules. There will be no relation to any structures of the secondary pulmonary lobule. The conditions showing random distributions are miliary TB. Always remember, miliary word shows random distribution. Any disease showing miliary pattern like fungal diseases, occupational disorders will show random distribution. Third is hematogenous metastasis. Sarcoidosis may show random nodules and LCH. In this picture we can see random distribution of nodules. This was a case of miliary tuberculosis. There is subpleural, periphyseal and centrilobular nodules which are not of any pattern. Here is an easy way for anatomical nodule localization. Once you see the nodules, first check the subpleural surfaces. Subpleural nodules are the ones which are in contact with the visceral pleura or the fissures. If subpleural nodules are present or absent, if they are absent, then it's definitely centrilobular distribution. If it is present, it can either be perilymphatic nodules or random nodules. We discussed the conditions. Perilymphatic nodules will have patchy along the septa, along the peribronchovascular region. Random nodules will have no particular pattern of spread. Next, coming to linear abnormalities, we discuss interlobular septal thickening, parenchymal bands and subpleural lines or bands. Coming to interlobular septal thickening, here is the interlobular septa and normally it's 0.1 mm thick. If any thickening is seen, then this is because of dilatation of the veins which are running through it, or it can be infiltration by fluid, fibrous tissue or cells, or it can be because of infiltration of lymphatics by the disease. Now, interlobular septal thickening is of two types. First type is when there is smooth interlobular septal thickening. Next type is when there is nodular interlobular septal thickening. This is also called as irregular interlobular septal thickening. The smooth interlobular septal thickening is seen in cases of pulmonary edema. Nodular one is in sarcoidosis. Smooth septal thickening. The conditions which cause smooth septal thickening are pulmonary edema. These are the ones which are known as curly B lines in case of pulmonary edema. Next condition is pulmonary alveolar proteinosis. Next we have lymphangitis carcinomatosa, pulmonary hemorrhage, and infections like pneumocystis jirovecii, amyloidosis. These are the conditions. Nodular or irregular septal thickening is seen in conditions like, again, nodular is seen in lymphangitis carcinomatosa, sarcoidosis, lymphocytic interstitial pneumonia, amyloidosis. Nodular is because of lymphatic spread. Irregular, sometimes nodular irregular are used differently, sometimes simultaneously. Irregular is caused because of fibrosing lung diseases like chronic hypersensitivity pneumonitis and sarcoidosis and usual interstitial pneumonia. Here is a case of smooth septal thickening. Here we can see this is a case of pulmonary edema in which we can see infiltration of the interstitium with fluid. So these are the ones which are known as curly B lines on X-ray. Nodular or irregular septal thickening. This is a case of sarcoidosis. Here we can see that irregular or nodular interstitial thickening. And this is a granulomatous infiltration of interstitium. Coming to second linear opacity, that is subpleural lines. These are curvilinear opacities less than 10 millimeter thickness. These are usually parallel to the pleural surfaces. Remember that these are the subpleural lines parallel to the pleural surfaces. These are nothing but atelectatic opacities, fibrosis or inflammation along the tissue. See, here we can see the subpleural lines or bands. Other thing which can see in this image is consolidation. Here we can see some infection. Coming to the third increased opacity, that is ground glass opacity. Here ground glass opacity means hazy increase in attenuation which does not obscure vascular markings. Very important, it does not obscure vascular markings. And GGO as such is a non-specific finding. So we can see some hazy increase in attenuation. It's non-specific and not a diagnostic opacity. So the conditions which cause this is diagnosed by patient symptoms. So GGO is considered as active and potentially reversible disease unless it's proven otherwise or unless accompanied by some other findings. Conditions causing GGO can be infections like parasitic, fungal, pyogenic. Pulmonary hemorrhage can cause ground glass opacities, pulmonary edema, etc. So here we can see this geographic patchy increased areas of attenuation. These are the ground glass opacities. Here they do not obscure vascular markings. That is the definition of ground glass opacities. The last increase in lung attenuation opacity we are discussing is the consolidation, which we see on HRCT. After this we will discuss decreased lung attenuation opacities. So what is consolidation? It is increase in attenuation which obscures the underlying vasculature. The ground glass opacity which we discussed did not obscure the vascular markings. That is the differential factor. So here we can see multiple alveoli usually are filled with air, but here if they are filled with anything other than air, that is called consolidation. Initially it will be ground glass. When it is completely opacified, it is called consolidation. So once the alveoli are completely filled, they will obscure the vascular markings, and the bronchus or the centrilobular bronchiole is seen through the opacity. Alveoli can be filled with fluid, pus, blood, or cells. Fluid, like in cases of pulmonary edema, pus in cases of pneumonia, blood in cases of pulmonary hemorrhage or contusion, and cells in cases of neoplasm. Yes, all these can cause consolidation. Now this will obscure the vascular markings, but the bronchiole is seen through the opacity. So this is itself known as the air bronchogram. So what is definition of air bronchogram? You saw. Here we can see this is consolidation where vascular markings are not seen, but air bronchogram is seen. This was a case of pneumonia where we can see the patent bronchioles, and in later stages even they get filled with the contents, and those are also obscured. In second part of the video, we'll talk about conditions causing decreased lung attenuation. These are emphysema, bronchiectasis, cystic lung diseases, and honeycombing. We'll see in detail. So first we have emphysema. What is emphysema? This is permanent abnormal enlargement of the air spaces. So air spaces we are talking about are alveoli in emphysema. So these are the air spaces distal to the terminal bronchiole. So it involves acinar bronchus, acini, plus there will also be destruction of the air space walls, which we can see on histopathology. So there are types of emphysema. First is the centrilobular or centriacinar emphysema, paraseptal emphysema, and panacinar emphysema. So we'll see what is the difference between these three. So along the centrilobular area, whatever air spaces are dilated, it's called centrilobular emphysema. This emphysematous change will have dilated air spaces with imperceptible walls. So paraseptal is along the pleural spaces, and panacinar is diffuse or complete destruction of the alveoli. We'll see each of them by imaging how they look. So centrilobular emphysema is upper lobe predominant, paraseptal also. Panacinar will be diffuse. Centrilobular seen in smokers, paraseptal seen in smokers, also in non-smokers. Panacinar is seen mainly in alpha-1 antiproteinase deficiency. So centriacinar, paraseptal, and panacinar we saw. So here we have abnormal enlargement of air spaces due to destruction of the walls of alveoli. These are the air spaces distal to the terminal bronchiole. This is a summary of emphysema. So here we can see these black spaces with thin imperceptible walls. These are the dilated air spaces with no perceptible walls. This is centriacinar emphysema. Next, along the pleural spaces, along the fissures, we can see paraseptal emphysema. These are dilated air spaces with somewhat perceptible air walls along the air spaces. These are identified due to their location. So they have thin definable walls. These can undergo spontaneous pneumothorax due to proximity to the pleural surface. Next we'll see panacinar emphysema. Here we can see early stages of panacinar emphysema, random distribution. Later stages it will show something like this, complete destruction of the air spaces. Coming to the next opacity with decreased lung attenuation, that is bronchiectasis. Bronchiectasis definition is localized irreversible dilatation of the bronchial tree. This is before the terminal bronchioles. So distal to terminal bronchioles it's emphysema, proximal to terminal bronchiole it's bronchiectasis. There are multiple types. Condition showing bronchiectasis is post-infectious cystic fibrosis, aspergillosis, airway obstruction, etc. Coming to types of bronchiectasis in detail, there is cylindrical bronchiectasis, in which there is linear, non-tapering, tram track appearing bronchiectasis. On cross section, it will show signet ring sign with dilated bronchiole and pulmonary arteriole along its wall. Next type we have is varicoid type or varicose type of bronchiectasis, where there will be these beaded appearance of the airways. Next is cystic bronchiectasis, where there are cystic dilated spaces of the dilated bronchioles which may or may not show air fluid levels when there is persistent infection within them. On imaging, we will see these three types. Cylindrical bronchiectasis looks something like this. There is linear non-tapering bronchi which gives tram track appearance. Next is the varicoid type or the varicose type of bronchiectasis. Here we can see beaded appearance of the dilated bronchioles. Next is the cystic type. Here we can see grape bunch like appearance of cystically dilated the air spaces with air fluid levels. So bronchiectasis definition is bronchial dilatation with increased bronchoarteriolar ratio. We saw the signet ring sign. Next, what we have to look for is the lack of bronchial tapering. There will be visualization of the peripheral airways just within 1 centimeter of pleura. Usually airways are not visible. In bronchiectasis they are visible. We should look for any mucoid impaction or air fluid levels if they are present or absent. And we should see the bronchial wall thickness. So here we can see lack of tapering. There is thickened bronchiolar wall. Here we can see increased bronchoarteriolar ratio. To next set of diseases causing decreased lung attenuation, they are cystic lung diseases. We will discuss only the major types. First is Langerhans cell histiocytosis or LCH. Next is lymphangioliomyomatosis or LLM. The third important one is lymphocytic interstitial pneumonia. These three you have to know for exams. Other ones are post-infectious pneumatoceles, amyloidosis, Birt-Hogg-Dube syndrome, cystic metastasis and follicular bronchiolitis. We'll discuss few of them in detail. Langerhans cell histiocytosis, also known as LCH in short. Cysts will appear something like this. They are caused in smokers with upper lobe predominance of opacity. There are bizarre shaped cysts which do not look alike. See, there are multiple variable shaped cysts which can undergo spontaneous pneumothorax. Next is lymphangioliomyomatosis, short known as LLM. They are seen in women in childbearing age having diffuse distribution of cysts which are almost uniformly shaped. Yes. Next we have lymphocytic interstitial pneumonia, in short known as LIP. So in this is a connective tissue disorder like Sjogren syndrome or anything. This LIP is seen. Here we can see cystic lesions which are 1 to 30 millimeter in range. They are associated with septal, fissural thickening, etc. with centrilobular nodules. Post-infectious pneumatoceles, we can see here the cystic lesion between the ground glass opacity. Causes can be Staph aureus pneumonia, AIDS, pneumocystis jirovecii. So there are associated ground glass opacity, and cyst will almost evolve with the bronchopneumonia as the disease progresses. So nodule will get converted into cyst. Coming to the last, decreasing attenuation opacity, that is honeycombing. They are the thick-walled air spaces with clearly defined walls, usually seen in the periphery along the pleura. So initial definition was that there must be more than 3 layers of cyst stacked upon each other to be known as honeycombing. But now even one layer is enough to be called as honeycombing. So here we can see along the pleural surface layering of the cysts with definable walls. So more than 3 layers was called. Now even one layer is called honeycombing. One layer of cyst is also enough. So the walls can be 1 to 3 millimeter thick. Conditions which show honeycombing changes. The first and foremost and most important one is the usual interstitial pneumonia known as UIP or idiopathic pulmonary fibrosis. They're the same thing. In non-specific interstitial pneumonia, diseases like sarcoidosis, and in radiation fibrosis also we can see honeycombing changes. Here we can see classical case of UIP. This was. Here we can see cysts with clearly defined walls along the pleura. Most probably these are seen in lower lobes. There is associated traction bronchiectasis seen in this case. This was a case of usual interstitial pneumonia or idiopathic pulmonary fibrosis. Honeycombing change is usually a marker of end stage lung disease. For more such videos, please like, share and subscribe our page on Instagram and YouTube at Radiology Doodles. For more videos, comment below and I'll try to do those videos. Thank you.